This video will be on Natalizumab, an important multiple sclerosis drug. It is a humanized monoclonal antibody approved for treatment of multiple sclerosis. Its mechanism of action is based on its binding to the alpha-4 subunit integrins of beta-1 and beta-7 subtypes, which is present on the surface of mononuclear leukocytes, preventing them from binding to the endothelium of blood vessels. Hence, it decreases inflammation by preventing leukocytes from crossing the blood-brain barrier. What are the clinical indications? First of all, it is effective in relapsing remitting multiple sclerosis, including the clinically isolated syndromes. Also, for active secondary progressive multiple sclerosis, and also it can be used for Crohn's disease. It is given 300 milligrams, which is infused over 1 hour. The patient should be monitored for also 1 hour for the possibility of hypersensitivity reaction, which can affect 4% of the patients. Urticaria and anaphylaxis can occur as well. This medication is repeated every 4 weeks. Now, what about its effectiveness in multiple sclerosis? It acts to decrease the annual relapse rate by 67%. Also, there is 80% reduction in the MRI T2 in new or enlarging lesions. Also, it decreases gadolinium-enhancing lesion by 92%. Its adverse effects can include hepatotoxicity. Also, it increases the risk of herpes simplex or varicella zoster virus, meningitis or encephalitis, and increase the possibility of malignancy like primary CNS lymphoma and melanoma. However, the most severe complication is progressive multifocal leukoencephalopathy, or we call it PML. PML is a rare opportunistic infection caused by John Cunningham virus. It's called the JC virus. Factors that increase the risk of having PML include positive JC virus antibodies, longer treatment duration more than 24 months, and prior use of other immune suppressant agents. Clinical features of PML can include coordination difficulties, speech impairment, visual deterioration, memory loss, and worsening of motor and sensory deficits. MRI can help us for the diagnosis of PML, showing large confluent T2 and flare lesions that can involve the U fibers and the thalamus, with a sharp margin at the cortico-subcortical junction and L-defined inner borders. Now, how does PML is treated? We need 3 to 5 sessions of a plasma exchange, which can wash Natalizumab over 2 weeks. Sometimes antiretroviral treatment with corticosteroids can be used. The use of Natalizumab in a pregnancy can be a little bit challenging. Although transplacental transport has been recognized in the second trimester, it has not been associated with low birth weight or major congenital malformations. 2 approaches are available to deal with this issue. The first one is to continue throughout the pregnancy, with infusion frequency is extended to every 6 to 8 weeks until the 32 weeks of gestation, where the medication is stopped in order to prevent the transient thrombocytopenia and anemia of the newborn. The second approach is washing out period of 3 months before stopping the contraception. This can increase the risk of serious relapse in the next 4 to 6 months following stopping the medication by 40%. So it is recommended to start with another CD20 antibodies like rituximab or ocrelizumab for 1 month before stopping the contraception.